Hello, Nashville. Thank you so much for having me. Chanting a little Dolly Parton here, one of my favorite singers, so if they let me sing, I might sing 9 to 5 if I had a song. But, oh, I need a clicker. Thank you. Hey there. Thank you guys so much. So I grew up, actually, my first time here in Nashville, I grew up about 6 hours away in a small town called Washington, Georgia. And where I grew up, no one that I knew ever went to the doctor for anything unless they were seriously ill, or if they went, it was definitely to the emergency room. As a matter of fact, I remember growing up, my mom and family would say, oh, that hospital, they kill people over there. And I thought, okay. As I become a doctor and I look back, people's diseases had progressed so far, there was not much that the hospital or the doctors were able to do. But I also knew we had insurance. I was able to go through my entire college career, but without ever having a pap smear or learning about self-breast exams. So we never accessed preventive care when I was growing up, and I really didn't know much about it. At age 20, I had my first visit to the dentist. I had a cavity, I was in a lot of pain, and the dentist gave me a choice. He said, look, you can have an extraction, or you can have a root canal. And I was 20 years old, and he's explained the root canal. I'm like, I don't think I want that. That sounds painful. I'll take the extraction. I thought I was making a rational decision, but because growing up I didn't know a lot about it, I made a choice that actually impacted me many years down the line, and in my 30s I was able to take advantage of new technology and correct it. As I look back, I would hear my mom say, so-and-so died, this person died, and at the time, these people were in their 40s and 50s, and I couldn't put it all together at the time, but I knew that many of them did have health insurance coverage, but they were still dying early, and they were dying from preventable conditions like diabetes, high blood pressure, high cholesterol. And I'm sort of wondering there, what's going on? It definitely inspired me to continue in my career heading towards medicine and the practice of. As a young medical resident out in California, as learning internal medicine, I began to see patient after patient, again, who would present with advanced cases of conditions that were related to very treatable and manageable conditions like diabetes, high blood pressure, cholesterol, hepatitis, et cetera, and begin to wonder, well, why is that? Why is it that people have access to care, but we're still seeing progression of disease that's extraordinarily remarkable, and it will impact their ongoing sort of morbidity, disease burden, and their ability to live a healthy and happy and highly functioning life. It was clear that at that time, primary care and prevention, which is what I was studying and learning to be, was failing many of our patients, many of my patients. So insurance was important, but it wasn't the only issue. When I landed in Chicago and began the practice of medicine on the South Side, I realized that, wow, I'm seeing over half the people I'm seeing are actually covered. What's going on here? What is it that we're missing as we think about the treatment of conditions that I was seeing over and over, but people weren't managing them well? And it really disturbed me so much that I said, gosh, I've got to do something about this. I realized as I looked at the communities that many of my patients were from, that they faced a lot of obstacles and challenges getting to the care that they needed. It wasn't as simple as having insurance. In fact, it seemed to be a lot more complicating factors. As a scientist, I realized as I looked at the data that, well, this transcends race or ethnicity. What's the factor there? Is there something predisposing my patients to not following up and not getting the care that they need? What was getting in the way of access even when they had healthcare insurance? Well, what we figured out is that actually, if you look at all the data, it's really low income that has the biggest impact on health outcomes in our country. Where you live matters too. And as we look at the data, there's a lot of data that shows you that where people live influences and has a great impact on their healthcare outcomes. Low-income and low-resource communities often have low-resourced areas around them, meaning there's not much that they can access that's beneficial for them. Sometimes Health plans or providers may have to intervene to overcome barriers that people are facing and obstacles that they're facing. Transportation is one that we know is important. You gotta get there. Sometimes for families with childbearing age, childcare is important. Wow, mental health, we really need to think about it. We know that it's there, and many times we don't pick it up because we're not looking for it. It may get in the way of how people access health care or even recognize that they have a mental health condition and may have a chronic condition that would do well if it's better treated. Sometimes people just don't want to go to the doctor by themselves. They may need support. Some people are afraid of doctors. That's not unusual. I know I took my husband home. He's also a physician. We were in our late 20s. And my mother said to me, she was just staring at us. She goes, "You all don't act like doctors." I said, "Mom, I'm your daughter." I'm not. So it's as if a doctor might be an alien, right? So we have to realize that there are things like white coat syndrome or just myths and fears related to seeing a doctor. And then follow-up. Sometimes you get there, but then the doctor asks you to come back multiple times. That might get in the way if you're dealing with a low-income and low-resource situation. Now, the social and economic factors, if you're in a low-resourced environment, can be paralyzing. What we know is from a study done at Princeton and Harvard is that the cumulative cognitive load of excessive stress can take you down 13 IQ points. The ability to deal with a doctor's appointment or anything but an emergency, our patients just won't have that. Other things are important. Well, when I began to really listen to my patients and understand, I really want to understand, well, tell me more. You don't want to take the medicine I'm prescribing for your high blood pressure. Well, will you take anything? And they say, "Doc, I take vinegar and garlic every day." I said, "Okay. Vinegar and garlic. How about I add a little bit of this little water pill here, hydrochlorothiazide, it's low side effects. You continue to take that, and let's see if together they might work." And you know what? I actually won a lot of battles just meeting people where they are. But that's real. People have their own remedies, and in many communities, they may approach it, healthcare, way different than the doctor might approach it, and we're gonna have to take some of those things into consideration. In much of my medical practice, my patients would accuse me of experimenting on them. Often you might start a medicine, your doctor might start a medication on you. Let's say you're taking something for cholesterol. Might start you with a low dose and then progressively increase the dose over time. Well, my patients would say, "Doc, why are you doing that? Like, aren't you really smart? And then you go to all these schools, shouldn't you know which one works and how much?" I said, "Well, no, we have to sort of test your tolerance. Every individual responds differently." But we often found that when I said I had a medical practice, my patients thought that meant I was practicing on them. So these are things that you gotta think about as you deal in different communities. You wanna understand what are the myths, the cultural mores that influence how they think about medicine. What are those things? And we have to really think about acknowledging those. Now, it's not just the south side of Chicago where this occurs. When I went home as a young doctor and I began to talk to my own family, I found that a lot of what I was seeing in Chicago, I saw it in Washington, Georgia. So it turns out that these myths are largely, they're around. And what's important for the medical community is that we address those when we're trying to meet patients where they are to get them on track. Now, I'm solution-oriented. Give me a problem, I want to find it. So I sort of studied all these problems over 15 years, and I said, you know what, I'm going to start a company. We're going to solve this. I'm going to do it. So first, we start with individual issues. We want to understand what is getting in the way of a person accessing care. We talked about all the different obstacles that might impact a person's approach to healthcare. Then we have to think systemically. What are the system barriers that are in a community? We talked about barriers in access in low resource communities. We have to understand those. We also have to understand the disease burden in those communities because we want to be well equipped when we go in to help and intervene and meet people where they are, that we know what they're dealing with. The science of that is called population health. You understand the broader community, and then you can really hone in on the individual and be effective. So you arm your staff with great tools, they're able to go out and really make a difference. Disease and burden is important. Understanding where you are, what's going on in that community. There's a community in Chicago called Humboldt Park. It has the highest incidence of diabetes in the city. Well, before you go into that community, you really need to understand, how do people think about diabetes in that community? Because when you go in, you're gonna wanna be armed with that information so that your starting point makes sense for where you are. Mental health, we talked a little bit about it before, really important. It is, for most, a chronic condition. So it bears and needs the same respect as diabetes and high blood pressure and hypercholesterolemia, because it's going to require ongoing contact with the healthcare community to support that person to get what they need. And also, it can mask other conditions and make people less likely also to seek care for conditions that could easily be treated and managed. So we take all this information and we can move forward much more effectively managing that dollar that we're spending on healthcare and getting better outcomes. I'd much rather spend the money upstream on prevention and treatment of these conditions than downstream, losing a foot, going on dialysis, suffering from low exercise tolerance, et cetera, when your heart starts to give out. Now, at the company we started, we went really local. We believe healthcare is local, right? That's what we've been talking about, communities. What do you see in communities? How do you best understand them? So we locate employees locally, we hire from local, we train local, healthcare is local. So we're gonna build capacity in those communities by hiring people from them to participate in improving the health of their own communities. Forge creative partnerships. Where do members and patients go? We wanna be everywhere they are. That's churches, schools, other not-for-profits that are in the community doing great things. Technology is important. Our folks are enabled with technology that allows them to, in the field, if they're in a certain community, they can pull up a zip code and say, aha, this community has this percent of diabetes, this percent of hypertension. We also know about the place they're in. We can look and see, this community has 6 churches, 35 liquor stores, 3 playgrounds, right? We know what people are dealing with, because you don't want to tell people to go exercise if there's really nowhere for them to go, right? So you want to know your community. Our folks are digitally and technically enabled to be able to do that. So while health insurance is important, and I agree, it is a great starting point, our folks may not be completely enabled and equipped to take advantage of what that access offers. So we want to help them out. We want to begin to coach them on, yes, these doctors are in network. This is where you can go and begin to engage there. If you want someone to go with you, we'll send someone with you so that you can get the care you need. It's much better to invest upstream than to have to go downstream and spend money on a foot that's not working, on a heart transplant, et cetera. Many things, if we deal with them upstream, we then have a healthcare system that is much more efficient, effective, and hopefully cheaper for all of us. Obstacles, we have to deal with them and think about them. So if we think the forward, progressive, next generation payer and providers who are rendering these insurance products, that we're aware of these obstacles and we're ready to coach and place our members. And then we can take it global. I think that the science of community is something that we can take all over the country. We learn about communities, we can go all over the world, implementing, improving, and hopefully saving lives. If we'd had a system like this when I was coming up, I think I might still have that molar. And the people that my parents, who were dying early, might still be alive. Thank you.